topic that we chose today was, are there any interventions beyond pharmacotherapy and surgery for management of chronic diseases like obesity, diabetes, high blood pressure, or dyslipidemias? May I have the... Thank you. So I have no disclosures or no conflict of interest. So the objective, understand the role of intensive lifestyle interventions in management of obesity and diabetes, identify strategies to improve adherence to diet and lifestyle for long-term maintenance of weight loss. So why should we talk about obesity? And this is because the data from Statistics Canada 2013 shows that nearly 1 in 4 Canadian adult is obese, and 1 in 9 have class 2 or class 3 obesity. So there's a huge burden and a huge need to address this disease. Gone are the days when obesity was considered a cosmetic disease or a disease of the behavior. The current consensus and recommendation is that obesity should be treated as a chronic disease. It is a complex disease with a multifactorial etiology, and it's associated with increased risk of numerous other diseases, including diabetes, increased risk of CVD, hypertension, major depression, sleep apnea, osteoarthritis, fatty liver disease, fertility issues, cancer, and the list goes on. So like I said, obesity is a multifactorial disease, and the etiology could be in genetics. It could be due to biological conditions. Things like maybe they have underlying endocrine disorders, for example, hypothyroidism, Cushing's, just to name a few. They could be on certain medications which promote weight gain. For example, steroids, for example, atypical antipsychotics, for example, some antidepressant medications. And of course, behavior plays a big role. So I always talk to my patients about sleep, stress, diet, and exercise when I talk about behavior. And of course, socioeconomic and cultural factors play a major role. I'm going to spend just a couple of minutes on the pathophysiology of obesity and how the body handles hunger, what makes us reach for food, and how the body handles its fat stores. So a lot of signals from the periphery. For example, when we are hungry, ghrelin is secreted from our stomach. Now that's a hunger-promoting hormone. It goes and acts centrally on the hunger and appetite center in the hypothalamus, causing that urge to eat. And once we have had some food, there are other hormones secreted from the intestines, namely GLP-1, it could be CCK, there could be vagal signals going back to the brain, and then they send the signal, okay, there's food there in the body now, and we can stop eating. But sometimes, even after we have had a full meal, we still crave food. We crave for that extra chocolate after a meal. We crave for some snacks, maybe once we're sitting down on our sofa after a meal. And that's where the rewards or the mesolimbic system comes in. But that's not all. Someone has to make those decisions as to whether or not to eat, how much to eat, what to do when presented with temptations, when presented with different food cues. And that's where the frontal lobe comes in, because it is our executive decision-making center for cognitive function. Add to this hedonistic responses to food, conditioning, subconscious and mindless eating, and we have lots of ways in which we are putting foods in our body and the way the body is handling fat. There's also lots of signals from the periphery, the adipokines, namely leptin and adiponectin there. And our body has a very good homeostasis for all different physiological functions. Weight is one of them. So the body tries to regulate energy expenditure by energy homeostasis. And it tries to maintain the weight around a set point through a lot of adaptive mechanisms, which we'll talk a bit later. So what is the current what should I say, what's the current clinical practice when it comes to managing chronic diseases like obesity and diabetes? I say lifestyle is the foundation. And again, like I said, diet, exercise, meal replacement therapy, and behavior interventions. Pharmacotherapy, of course, is a mainstay, especially in diabetes. So lots of oral and injectable hypoglycemic agents, including insulin. Sorry. Okay. And the currently available medications for management of obesity in Canada, we have 3 of them: orlistat, liraglutide, and naltrexone bupropion combination. And of course, there's the option of bariatric surgery for those who are eligible. Bariatric surgery has been shown not only to help people lose weight, but also it has been shown to have very good results in remission of diabetes. So why should we talk about interventions other than pharmacotherapy and bariatric surgery? Because, one, the pharmacotherapy for obesity, the medicines, they're not covered. So the patients have to either pay out of their own pocket or their insurance may cover it. And the dropout rate after starting someone on these medications is very, very high. And again, usually the first response I get from my patients when I ask, you have an option of bariatric surgery, would you like to consider it? It's like, no, I want to do it with other means. And that's why I thought let's talk about some of the other interventions which we can give to these patients to help them not only manage their obesity, but also chronic diseases like diabetes. So the first thing I'm going to talk today is about meal replacement therapy. So what is meal replacement therapy? Now, in this, we recommend that the patient not eat the regular foods, but instead it's substituted by special drinks, shakes. In Canada, it goes by, the only Health Canada approved meal replacement is OptiFast, and we only get it in a shake form. But in the US, there are other varieties also available, like powders, which you could use in soups or maybe even chips, just to increase the palatability of these products. The idea is to maintain calorie intake around 800 to 900 calories, maybe up to 1100 calories, depending on what the initial BMI of these patients is. And this needs to be done under medical guidance. Why? Because there's a big risk of nutritional deficiencies, and also it may be associated with certain side effects. For example, constipation, nausea, and nutritional deficiencies too. Meal replacement could be a total meal replacement in which all the meals in the day are replaced by, for example, OptiFast. Or it could be a partial meal replacement in which 1 or 2 meals are replaced by these shakes. Now, the patients have about a 3-month period in which is the intensive phase where, for example, if they're on total meal replacement, so for those 3 months, they'll take only these shakes. But then afterwards, foods are gradually reintroduced. And this is done under supervision. In our clinic, we do it with the dietitian, myself and Dr. Gupta, who's the endocrinologist. So the foods are gradually reintroduced slowly. And now in the maintenance phase, the idea is to maintain a stable weight. So we have managed to lower the weight, and now we're trying to maintain it. So does meal replacement work? Direct study was a landmark study, and it has been published recently. And why it's so important is because it's a primary care study. So this was done in 306 individuals who had type 2 diabetes between the age of 20 to 65 years, BMI 27 to 45, and they were not on insulin. So they were randomized either to receive a full meal replacement, and their anti-diabetic and anti-hypertensive drugs were gradually weaned off, and then the food was introduced slowly over next 2 to 4 weeks, and they received a structured support for long-term weight maintenance. Remission of diabetes was defined as hemoglobin A1C of 6.5% or less after at least 2 months of all anti-diabetic medications from baseline to 12 months. So what were the results? At year 1, it was seen that 46%, which is nearly half of the participants who were on intensive weight management program, they were able to achieve diabetes remission, versus only 4% in the control group who received just a regular care. And when these patients were followed up to 2 years, even at 24 months, nearly a third of them still had diabetes remission compared with only 2% in the controls. So meal replacement could be a very powerful tool here. What this study also showed that the sustained remission was linked to the amount of the weight loss. For example, individuals who lost about 10 kilos or 22 pounds, 64% of those participants were in remission at 2 years. Not only this, significant effects were also seen on blood pressure as well as lipids. This is another Canadian study by Dr. Judy Shaw's group in Ottawa. And they also looked at total meal replacement for 6 months in about 317 participants in patients who had type 2 diabetes. Again, these patients, they received group sessions through a dietitian, behavior therapist, or exercise therapist, a full meal replacement program here, 4 shakes per day, about 900 kilocalories per day for 6 to 12 weeks, and then on a 5-week transition period with regular food, and gradually the maintenance diet where regular food was introduced. And these patients had regular monthly group sessions. Again, what did this study show? That at 6 months, 30% of the participants were not taking their diabetes medications now. And even on those who were on insulin, there were about 74 patients of this group. 45% had either discontinued insulin, and 42% had their dosage of insulin reduced. And an average weight loss after this period at 6 months was about 47 pounds with total meal replacement. OPTIWIN study is another study which was done in overweight patients. So there were about 273 participants. And again, the idea was to do a total meal replacement for about 12 to 16 weeks with gradual reintroduction of food through week 26. And after week 26, the participants' calories were gradually reintroduced. And then a regular food-based diet plan was given to the control group. If you look at these results, patients on full meal replacement, they lost twice as much weight at 26 weeks, so 12% versus 6%, and also at 52 weeks. So these patients were followed for a year. That is 10% versus 5%. Okay, so these data shows that meal replacement could be a very good alternative therapy if we are trying to help patients lose a lot of weight. And that's been found particularly useful for pre-surgical patients where, for example, if a patient has to go for knee replacement and they're asked, okay, you cannot undergo the surgery until you lose a certain amount of weight. So meal replacement can be very useful in those patients too. I want to talk about intensive lifestyle management as another intervention. So what is intensive lifestyle management now? Usually when we give a routine care to our patients, okay, if they are overweight or obese, first of all, we ask them permission to talk about their weight. And then usually in routine care, we say, okay, please try and lose some weight. And then we see that patient in 6 months or in a year or even in 2 years. We may give them some handouts in our clinics, and the patient goes away. So that's just a routine care. We have told them what to do. We have given them handouts, but we have really not given them any other support. But in intensive lifestyle management, we give one-to-one individualized support to our patients. So based on patients' needs, based on patients' health, based on patients' cultural preferences, They work very closely with doctors, physicians, nurses, and dietitians to get specialized meal plans, which is very specific to those patients. Not only these patients undergo a lot of behavior modification exercises as well. I'm sure Jennifer is going to talk to us about some of those later in her talk. And then the other thing which distinguishes intensive lifestyle management from regular care is the frequency of follow-up. So these patients are followed up either weekly, bi-weekly, or monthly. Most of the time, they do get one-to-one support. If not, they're not able to make it in person, then of course they can get virtual support. Also, they are enrolled for group sessions where they can learn from each other's experiences. Coupled with this, an exercise regime, an exercise requirement, or the way they should be exercising, how much they should be exercising, and regular monitoring of these patients is very important. So that's what differentiates intensive lifestyle management from a routine management. The Finnish diabetes prevention study. Now, this was a landmark study which was done in patients with which was done in individuals, I should say, with impaired glucose tolerance. Now, what's unique about them is because this group, as we all know, is at a very high risk of progression to diabetes. So the investigators, they studied 40 to 64-year-old individuals with a BMI of more than 25. About 500 individuals were studied. And again, they were randomized either to receive general dietary and exercise advice at baseline and had annual physician's examination. That's what's routine care is. And they were the control group. Or they received individualized dietary counseling and increased overall activity. So what did the results of Finnish study show? They showed that at 1 year, the mean weight reduction in intervention group was 4.5 kilograms as compared to only 1 kilogram in the control group. And significantly greater improvements in metabolic parameters such as glycemic control and lipid profile were seen at 1 year. But one of the most important results from this study was this study was intended to be done for about 4 years, 3 to 4 years, but they had to stop this study because of these results. So the results was those who received the control group, the ones who received only regular care, their risk of diabetes was 20% as compared to only 9% in the intervention group. So this study had to be halted prematurely because they thought that it was unethical for the control group to let them just go and develop diabetes when they had such a good intervention which was preventing development of diabetes or risk of diabetes in the intensive lifestyle management group. Look Ahead trial is another landmark study which looked very closely at intensive lifestyle in type 2 diabetes. Now, this is a huge study of over 5,000 subjects. Again, they were randomized to intensive lifestyle intervention or to receive regular diabetes support and education. Median follow-up of this study was 9.6 years, so a big study with a long follow-up. So what did the results show? They showed that at 1 year, 8.5%, at 1 year, the amount of weight lost in the patients who were in intensive group was 8.5% versus 0.6% in the regular care group. And if you follow up these patients up to 8 years, now 8 years is a long duration of time in the weight or the obesity management world, even then, those who received intensive interventions, they were able to lose up to 4.7% of body weight as compared to 2% in those who received just a regular care. Not only this, diabetes remission was 11% in the intensive group compared with 2% in the control group at 1 year and 7.3 versus 2% at 4 years. So yes, intensive lifestyle intervention can also cause diabetes remission. And there was improvement in metabolic parameters, including HbA1c, and there was a reduction in systolic blood pressure. Now, 8-year follow-up data also showed that intensive lifestyle intervention produced clinically significant weight loss. So what is clinically significant weight loss? At least 5% of current body weight, because that has been shown to have significant health benefits. So at year 8, in 50% of the patients with type 2 diabetes. Now, I want to say here, these patients were actually followed very closely, and when they asked that what was that helped them keep the weight off, the key weight control behaviors which came out of this look-ahead study was increased physical activity, reduced caloric intake, and frequent weight monitoring. And that brings us to the next topic. So the reason I introduced 8 years here is because once the patients start to lose weight, weight regain is a physiological phenomena. It will happen in everyone, but is there a way to prevent it or to reduce the amount of weight regain? Now, I would like to bring to your notice here, I don't know how many of you are aware of The Biggest Loser. So yes, so what they did in Biggest Loser, they got these individuals together and gave them a challenge. So these individuals, they had a baseline body weight of about 150 kilos, and they gave them a challenge to lose at 30 weeks a certain percentage of their body weight. So the weight reductions which were achieved on an average, this is a very busy slide, please just look at the top line there. So they had a starting weight of about 150 kilos, and at the end of 30 weeks, the average weight was about 90 kilos. So they've had a big reduction in their body weights. But when these patients were followed up over the next 5 years, look at their weight, it's 131. Most of them had regained almost, I won't say all, but quite a significant amount of weight back. So weight regain is a known phenomena. Now, these individuals were studied very closely by Dr. Kevin Hall from NIH, and they did a lot of metabolic studies in these patients along with behavioral studies, and what they found was, look at this, the metabolic adaptation. So what you would expect is when you have lost weight, the body would probably adapt to a lower set point, but that's not what happened. What's happened is, as the person loses weight, the body loses its caloric expenditure. So the energy expenditure decreased in these individuals. And they had a predicted net lower energy expenditure of 500 calories per day. That's a lot. So what's weight regain? Like I said, it is a normal physiological phenomena, but there's a lot of inter-individual variation in this. I cannot predict that if two people have lost, say, 10 kilos of weight, what's going to be their weight regain in the next 5 years. It's very different from person to person. We still do not know all the mechanisms behind it, but it's probably something to do with metabolic adaptations of the body. So it's greater than predicted decrease in resting metabolic rate and energy expenditure, as we just saw in the Biggest Loser study. Increase in hunger and appetite. So the hormone which promotes hunger, that's ghrelin, it's been found to be increased in these individuals once they lose weight. And leptin, which is a hunger, a fullness hormone, that is decreased. There's increased hedonic responses to food, and the physical activity over the years just wanes away. So if weight regain is kind of bound to happen, then are we kind of here fighting a losing battle against weight? Now we have real-time data from National Weight Control Registry. This is a real-world data. And this registry is currently tracking over 10,000 individuals who are at least 18 years of age, and they have maintained at least 30 pounds of weight loss for a year or longer. And what's interesting about this weight control registry is once the data comes in, there's a great variation and diversity in the weight loss journeys of these patients. So 80% of them are women. The weight losses have varied between 30 to 300 pounds. So big range there. And some people have only been able to maintain that weight loss for 1 year, while others have kept the weight off for 66 years. And there are both rapid and slow losers. Again, this is something which is asked very often in our clinics. If I start this medication, if I start this intervention, if I enroll for this program, how much weight am I going to lose and how soon? And my answer is, I don't know. Each person is so individual, it's so different, it's all an individual response. And these participants used a wide variety of interventions for weight loss. For example, about 45% did it on their own, but another 55% used the help of a program to help them lose weight. So here is something which I have taken straight from that website, and it says there is a variety in how the registry members keep the weight off. Most report continuing to maintain a low-calorie diet, low-fat diet, and doing high levels of activity. And they come up with some numbers. They say 78% of these individuals, they eat breakfast every day. 75% weigh themselves at least once a week. 62% watch less than 10 hours of television per week. 90% exercise on an average about an hour a day. So if they're able to keep the weight off, then they have to work hard for it. So as I come towards the end of this presentation, I want to summarize that when we talk about intensive lifestyle interventions, the first thing it's very important to do is a readiness assessment. Weight loss is not easy. It needs a lot of commitment and a lot of patience from both the sides, the patients as well as the healthcare providers. And you have to make sure that the patient or the individual is actually ready to make those changes. So we do a readiness assessment. We usually use a traffic light symbol here. So green means go, they're ready to make a change. Red means we want to lose weight, but I don't think I can make any changes now. And yellow is they're the fence sitters. They may not. And again, as we talked, reduced caloric intake, increased physical activity, frequent weight monitoring is very important. And the support could be either as individuals or in a group, or it could be in person or via virtual means. But underlying all these principles, I think it's very important is that we do not make it into a fight or a battle to lose weight. It's very important to develop a positive body image, work towards developing that with your patient, raising their self-esteem. I would just like to finish off by saying that there are a lot of behavioral therapies. If you remember in my initial slide when we talked about pathophysiology, that it's the cognitive functioning in the frontal lobe which determines how we respond to food. So these therapies, including cognitive behavior therapy, acceptance-based therapy, mindfulness, all these are very useful tools to help patients achieve adequate or optimal responses. So the first thing we have to do is remove stigma and the bias when we see any patient or any individual who lives in a bigger body. Set smart goals and discuss the concept of best weight. The best weight may not be their ideal weight, but best weight is where they are in good health, they have a good functioning, and they have a good quality of life. It may not be their ideal weight or ideal BMI. I think perhaps most important is to provide them with resources, provide them with support on how they can kind of, I would say, try and lose some of this weight. And we have to provide them evidence-based weight management strategies. I talked a few non-pharmacotherapeutic and non-surgical strategies today, but pharmacotherapy and surgery, they are important pillars of weight management. And like I said, weight regain does happen. It's a big challenge. And it's very, very difficult to adhere to a particular lifestyle for a long time. So long-term support and follow-up of these patients will lead to the best health outcomes. Thank you. Any questions?